There we go. Perfect. Okay. Hello there, and welcome to this episode of the OncoPT podcast. Back in episode 176, I had on Dr. Susan Maltser, and we talked all about my literal most favorite article in cancer rehab of all time. In case you missed it, it's called A Focused Review of Safety Considerations in Cancer Rehabilitation. And it is absolutely the article. I have 2 copies floating around my office at all times. I reference it most of the time, like if not every day, most every day. And I recommend every single rehab therapist have their hands on it because it's so good. Well, today I have Dr. Susan Maltser back on the OncoPT podcast because the feedback overwhelmingly after that last conversation was, can we get her back on to talk more about bone metastases? And I'm so thrilled to have Dr. Susan Maltser back on the podcast. Dr. Susan Maltser, welcome back to the OncoPT podcast.
Thank you for having me. I'm always so honored by your engagement on this topic, and I can't wait to delve right into it.
Oh, okay. So again, if we want the amazing background of how you got to where you are, I highly recommend listeners check out episode 176, but we're going to dive right into bone metastasis because this is absolutely, in my experience, Susan, what most therapists are afraid of when it comes to the oncology patient population. Is that what you see too?
I think that's been my experience also, is that, we're so focused on helping people that we really don't want to do any harm.
Oh my God.
And there's a lot of dogma floating around in how, therapists were trained and how I was trained as a physician.
We're going to get right to kind of the crux of this. So for the therapist who is brand new and is like, what the heck is that? What are bone metastases? So we're using common language here.
Okay. So metastatic disease is basically the spread of cancer from one organ, usually a solid organ like a breast or prostate or a lung, to a distant part of the body. So that's what makes cancer, like a stage 4 cancer, is when it's metastasized to a different part of the body. And the most common place of metastasis is bone metastasis. So it's not infrequent for patients that have breast, prostate, lung. Those are most common cancers to have the spread of their cancer to bone. And it's not uncommon to discover that a patient has cancer by finding bone metastasis. So somebody that has back pain or may have had a hip fracture, and we find out, oh, that's because they have a cancer coming from somewhere else.
Right. I feel like this next question is going to ask you to solve world peace. But it is a really important question. Why do bone metastases occur in patients with cancer? Like, why does it happen? Why bone? Loaded question, I know, right?
So I may not be able to answer that. Cancer spreads via several mechanisms. One is via blood. The other is through just like molecular genetics, right? Like the cancer has an affinity for certain tissues. And so there's some cancers that have an affinity for bone, right? Whereas other cancers may have different affinities. Right. I don't know why cancer likes bone so much, but I can tell you that having bone metastases is much better than having other organ metastases. So for example, having bone metastases is a better prognosis than having, say, liver metastases or brain metastases, because bone metastases we can actually treat, and patients can live with them, which is why you and I see these patients, because they're living with them.
Right. It's interesting, at the start of our conversation, you mentioned that these are not uncommon. When I first started working as a student, I think because I saw so many more patients who were early stage cancer, right? I did not see a lot of bone metastases in that patient population. But when I actually started treating patients as a licensed physical therapist, I was at a different practice, different area. So many of my patients, probably 50%, had known bone metastases at the time that they were coming in to see me, like at evaluation. And so I very quickly had to go from this like mentality of, oh, like they're not that common, whatever, I don't really have to worry about them that much, to, oh, half my patients have them. And I need to get real comfortable with them really quick, because I think, like you said, we as rehab professionals are so deeply driven to help people and not hurt them. And we have a really negative association with bone metastases in the sense of, I don't want to hurt them. I don't want to break that patient. So I'm not going to touch the patient who has bone metastases, when in fact, this is entirely the opposite wrong approach to take with these patients.
I completely agree. I think, we want to be safe, but we do have guidelines in kind of guiding us in the safety of working with these patients. But I also always want to encourage people to think about what are we doing with them? So I think there's a spectrum of getting people out of bed if you're in the hospital, walking with them, right? Doing resistive exercise, prescribing exercise, like from a home exercise program, aerobic and strength, right? So there's a whole spectrum of things. And especially to the left side of that spectrum, where we're like getting out of bed, we're doing transfer training, we're doing ADLs, we're doing ambulation, like the patient is going to do that with or without you, right? The alternative to that is like bed rest and death, which we're not going to do. And even when you think about resistive training, I say, like, are you going to tell this patient to never pick up anything, like never pick up anything that weighs a few pounds, right? Like, what are we doing? We're not putting our patients through marathon training, right? So usually I have a presentation that I do, and it reviews some studies that are very interesting. So one study that I always talk about is a study done by Dr. Bunting, actually in the 80s, where they took 54 patients and they put them through acute rehab. And out of those 54 patients, they all had metastatic disease to bone.
Okay.
And they followed those patients over the course of several months, and 12 of those patients ended up getting fractures, but none of them happened in rehab. And many of them were silent, even the patient didn't know. And so the idea is that, like, if a patient is going to fracture, they're going to fracture because of disease progression, right? Like if you have a lesion in your humerus, then it's going to get bigger and bigger, and eventually it will fracture. Well, when it fractures, we can fix it.
Right.
But we can't tell you not to use your arm ever again, because that's not living. So I think just being comfortable with educating the patient that has bone metastasis, yes, they are at risk of fracture, and we can teach them things. We can teach offloading exercises. If they have spinal mets, we can teach them not to bend down, to bend with their knees. We can do falls prevention. We could educate them on fracture risk reduction.
Right.
But nothing we do is going to cause a fracture. And it may even make things stronger. So I don't know if you're familiar with Merrill's criteria. So Merrill's criteria,
but I know there's others who aren't. Yeah.
I'll just go over. Basically, there have been a lot of people kind of given thought to, like, what causes somebody to have pathologic fracture? Is it the size of the lesion? Is it in a weight-bearing bone or not weight-bearing bone? Is it metastasis that's osteolytic or osteoblastic? What is it? So Merrill's came up with this criteria, and basically the things they get the most points for the most likelihood to fracture are peritrochanteric location.
Yep.
So hip metastasis, right? Osteolytic. So, like lung cancer tends to give you osteolytic metastases.
Okay.
And then the thing that's probably most important is something called functional pain. So pain with movement, which like we are really experts at picking up, right?
Absolutely.
So if somebody has a peritrochanteric lesion and they have pain with stairs and they have pain with walking, that's functional pain.
Absolutely.
And so that criteria kind of guides you to when you should advocate for prophylactic fixation. And I've done this. I recommended people to get prophylactic fixation. So for example, if I have a patient in the hospital with a hip fracture and they have mets in their humerus and I need them to use a walker and they already have functional pain with that arm, I'd say, you know what? It's not a good idea for them to bear weight on that walker with the functional pain.
Mm-hmm.
Maybe they should have a prophylactic pinning,
Right.
and that's fine. But I think, for the most part, if they don't have a lot of pain with function at the level of their lesion, I am very comfortable with whatever.
Yeah.
There's also like a lot of evidence that exercise, not even rehab, but exercise can build bone in the area of the metastatic lesion. So my all-time favorite study that was done on this was done on prostate cancer patients with spine metastases. And what they did was they gave them exercise through the lesion. So if you had an L3 bone met, they gave you resistive exercises for your spine through L3. They did not exclude L3. And what they actually found is that those patients improved their bone density at the area where they had metastasis and are in theory supposed to be having bone breakdown.
Yeah.
Whereas the control group, who just had aerobic exercise, did not. To me, this is like the biggest like exercise is medicine, right? We don't have a medication or a surgery or radiation that can do that. So not only there were no fractures, but they improved bone density for those patients. So to me, I feel very comfortable prescribing resistive exercises.
It's so interesting you bring up that study, which first of all, I need to get my hands on. But, so many of us, again, because of training, because of, pre-existing beliefs, what have you, we are concerned we're going to hurt the patient, so we're not going to do anything at all. And one of the things that you said in our last conversation was so powerful, and it stuck with me so much, is that if we're not doing anything with these patients, we're only contributing to this increased level of sedentary time and breakdown of loss of lean muscle mass. We're certainly not helping the bone density. So like, if we're not doing anything about it, we're actively harming the patients. That's not helping. That is actually the opposite, the active opposite of helping our patients by not doing anything. And that has always stuck with me since that.
Right. And then also, like, if you think about it, some of our patients may be so debilitated, they can't get more chemo, right? Their performance status is poor. And so they need us to get their performance status up.
Right. And again, bone metastases in some cases, like, yes, they're aggressive, they are rapidly developing, etc. In some cases, that is not the circumstances, though. Sometimes these patients are going to have these for a long time, and they can be medically managed to the point that, okay, we've, the oncology medical team is saying, we've got this under control. Now we need to go do something about it. And I love that you brought up the whole patients may not be able to tolerate their ongoing chemotherapy regimens or, insert cancer treatment here because they're so deconditioned, they're so debilitated. That actively affects their life expectancy, right? Their prognosis, their outcome, their quality of life. And we absolutely, as the rehab staff, have an opportunity to intervene positively here, even for the patients, especially, I would say, for the patients with bone metastases.
Yeah. Absolutely.
What are some, and you've kind of addressed these already, Dr. Maltser, what are some myths people have when treating patients who have bone metastases? We talked about you're going to break him. We know that, that's false.
I think that's really the biggest one. Oh, so there are people who are always, they may be afraid of spreading metastases, right? So like,
Thank you.
if we, if we do a specific exercise, or if we use modalities, or if we do massage, right? Like those kind of things. And to that, I always just say, like, just use common sense. If you are worried about a hot pack or an ultrasound or whatever, then don't put it over the area that has the bony metastasis.
Right.
There's a lot of other body parts to treat. You know what I mean? But
yeah,
metastatic disease is a microscopic molecular genetic process. So we are not going to, like, with our hands, spread metastases, right? Now, I do think there should be some just like really common sense precautions. So yes, if a person does have that functional pain that we had talked about, then maybe don't do resistive exercise, right? Don't put a TENS unit right over the area of bone metastasis. Don't put an ultrasound right over the area of bone metastasis. Don't do massage right over the area of bone metastasis. Certainly I discourage my patients with bone mets to go to chiropractors and such because of, the high velocity maneuvers that are really contraindicated, especially with spinal metastases. But pretty much that's it. I don't think there's a lot of opportunity to harm people.
Yeah.
Like, I have never heard of harm coming to a patient. And this goes back to my training. So I remember as a resident, I was seeing a patient who had prostate cancer with spine mets, and he loved to row, like exercise row.
Yeah.
And I remember him coming to clinic, and the attending that I was working with basically like send him to therapy to strengthen his core muscles and his back muscles. And the goal was to get him to row. And I remember thinking, like, rowing is like such a physical thing.
So physical. Yeah.
But it's okay. And especially if it can give us our patients, something that they enjoy, something that they love. I think it's okay.
Again, not to throw back your article, because you heard last time I fangirled over your article like super hardcore. There are such like common sense guidelines in that article. So again, I will of course link to it in today's show notes so the listener has access to it, which it's free, first of all, like you can find this on the internet. But there's such good, like very common sense recommendations. And there's also another article by Grumeritz that came out. He's another physical therapist that I think it came out in 2021 and really broke down like, okay, if your person has a bony metastasis in this area, these are things you can do. These are things to avoid. And it's very common sense. It's like, okay, if that bone is compromised, then don't do things that are potentially going to like exert extra forces on that impaired area, but you're still exercising, you're still doing movements and mobility. And again, like you said earlier, patients are going to do a lot of these movements with or without you. So you may as well do them with them and make sure that they're using appropriate mechanics and posturing and body lifting principles and whatnot. Like at least it's in a controlled environment that you can kind of get ahead of like, hey, you know what? This is putting a lot of extra strain on you. Let's do it this way because it's going to be better for you in the long run. So you don't hurt yourself, not just in that area, but like, let's not hurt your back because you're lifting inappropriately. For example.
So the only thing that I would honestly avoid is if like you're doing something with a patient and they're telling you this is hurting me.
Boom.
Right. But if you're doing something and you're not hurting the patient, you're not going to cause a fracture. And actually yesterday I was reading this really interesting article about like the molecular aspect of exercise and bone mets. And they did this study with mice where they injected cancer cells into the tibia, like the tibial plateau of mice, and they had two groups. And the first group got a compressive force through the tibia, so where the bone met simulated R, and the second group did not. And then basically in the first group there was no bone breakdown because it created this, they're saying it created like a microenvironment that was anabolic, that it was building bone because of the compression.
Okay.
Whereas in the control group, the bone eroded.
Right.
So I guess what I'm saying, like we have, and I'm sure there's more studies like this. We're showing like that even if you have metastasis, if you don't have functional pain, you can help bone.
Yeah.
And to think that we're going to cause a fracture from some like, range of motion or a couple pound weights, it doesn't make sense.
Right. It's almost laughable. Like we don't necessarily see these kinds of these like restrictions we're imposing on ourselves out of fear. I don't feel like we see this in other patient populations. I feel like it's such an oncology thing of like, oh my gosh, the patient is fragile. We don't want to hurt them. We have to protect them. It's like, no, like their bodies need activity. They need aerobic training. They need resistance training dosed appropriately to help their health in general. And absolutely, like that is so cool about those studies that you're referencing, especially the mice. I'm hoping we get to see that translate like over into humans at some point, because
I hope so.
And that could change the game.
I hope so. But like, like that study I was telling you about, the exercise with the prostate and bone mets, that kind of is the same type of study, right? Like they were able to demonstrate the bone was built.
Oh my God, that's so
really
cool.
Really exciting.
That is so neat. One of the things that I was told when I was really, really early in my career, because I was working with several patients at the time who had metastatic disease, including bone metastases. And I told this particular therapist, I was like, I'm worried. I just like, I don't know if I'm going to hurt them or if, that's going to be too much for them. And she literally sat me down and she said, Elise, you're a good therapist, but you are not powerful enough to cause cancer to move with your hands. Going back to what you were saying earlier about, I am not going to make a metastasis spread with something I'm doing with my hands. Like, I think that implies that we have a super strong amount of power as like a human, and we just don't have that. Like, cancer is going to do, unfortunately, what cancer is going to do. And we need to be helping our patients in spite of whatever cancer is going to do, as long as we're being safe and appropriate with our exercise, with our interventions. So we've kind of teased these throughout the interview, Dr. Maltser, but what are some overarching safety principles, recommendations you would give for the therapist who is brand new to treating a patient with bone metastases?
Okay, so number one, assess if the person has functional pain. So if the patient has a humeral lesion, do they have pain with moving the arm? If they have hip lesion, do they have pain with walking, with doing stairs, with doing a sit to stand? If they have spine pain, if they have a spinal lesion, do they have pain with bending forward, bending backwards? Okay, so that's one.
Okay.
Two, I would assess like, what is the patient doing in their regular life? Are they walking? Are they doing exercise, right? Because for all you know, they're already doing everything that you're afraid of doing to them.
Right. Yeah.
And three, I would focus on education, right? We can teach fracture prevention, falls prevention. We can work on building muscle strength so that patients don't fall, so that their balance is good. And honestly, that's it. If they have really bad functional pain, I would encourage them to, find an orthopedic surgeon who specializes in oncology to see if they could maybe benefit from being prophylactically fixated. That's it.
Yeah. Okay, that ties in really well. So the last question I have for you, this actually comes from one of my audience members, and they asked, can you discuss pain management for bone metastases, especially spinal and rib metastases related?
So when it comes to pain management, I like to follow the WHO kind of pyramid for pain control, right? Which starts out with like your Tylenol, your Motrins, then goes into like adjuvant pain medications like gabapentin, and then on the top would be opiates. So
Okay.
believe it or not, patients with bone mets do respond to gabapentin, which is a nerve pain medication, because bone has a lot of nerve endings to it.
Okay.
So, we could start on Tylenol, we could try some gabapentin, but we can try some lidocaine patches for rib metastases. We can try nerve blocks, right? The ribs are innervated by those intercostal nerves that can be blocked. And then if patients are still having pain, we can try opiates. I do think that there's a lot of like stigma surrounding opiates.
Yes.
But I always tell my cancer patients, like, this is what opiates was designed. This is what opiates were designed for, right? Cancer related pain. And you have metastatic cancer, and nobody should be walking around in pain.
Right.
And I usually find that you need a multimodal approach. Sometimes CBD works, like, gotta try a little bit of everything.
Yeah. I'm so glad you brought that up. That is one thing that when I first started working with patients who had bony metastases, I was really surprised by the resistance of not every patient, but a good chunk of my patients were really resistant to taking their appropriately prescribed opiate medication exactly because of that stigma that you mentioned. And they would tell me, Elise, I am so afraid of becoming addicted. And again, there's a time and a place for opiates. And I think, unfortunately, the physical therapy profession as a whole has really jumped on the train, which I understand, of like, opiates are overprescribed, like not as many people need them, they're being abused, etc. But I totally resonate with that, Dr. Maltser, about like cancer pain. From what I understand, as someone who has never had that level of pain, is one of the worst pains a person can experience. It's debilitating, it is pervasive, it is all encompassing. And there's not like, there are certain points where it gets to a point where you cannot manage it with anything else. And opiates are the perfect solution for this. So I know I said that was my last question. This is going to be my last question. How can I, as the physical therapist listening to this interview, how can I have a conversation and educate my patient on they've been prescribed opioids or pain medication, whatever that is, as a tool to help them do their daily activities, and how important it is to adhere to this pain management strategy so that they can do their stuff? Like, what would you tell the therapist who's really struggling with that because they know that patient's in pain, but the patient is hesitant about taking that pain medication for their bone mets pain, for example?
I mean, I would just say to the patient, look, nobody should suffer, right? Life is short. We want you to live your best life, and nobody wants you to suffer. And we have these tools. And if you had high blood pressure, you would take blood pressure medication. And we've tried Tylenol, we've tried other medications, and they haven't worked. And that, I worry that if you don't treat your pain, you're going to be sedentary, and you're going to be depressed, and you're going to be stressed and not able to, physically or emotionally participate in your life.
The physical and emotional participation like really hit me. That's such a big one. I mean, how many of our patients, their whole reason for being and like going through whatever is so that they can be around their family, like grandkids and children, and oh, that's a big one. That's a big one in my community. Oh my God. So good. That's really powerful. And like I said, that was something that really surprised me as a newer therapist, of how many patients were really resistant to it. And so I think that's a really powerful tool for therapists to have and to be able to have that conversation with patients. Where can people follow you, find you on Twitter? Because I know you're on there.
They can find me on Twitter. I feel like I'm more of a, background participant, but I'm on Twitter and I'll try to tweet more cancer rehab things. I don't even know my Twitter handle, to be honest. Like, I should know. I don't even know it.
I'll find it. I think you're a lurker on Twitter like I am. Like, I'm a really good lurker where I don't comment or like post. I just kind of watch what's happening.
Yeah. But I'll try to do some like cancer rehab content.
Perfect. Anything else you'd like to leave my listeners with today, Susan?
No, just they're very lucky to have you and to have this community who is, so passionate about providing care to cancer patients because, they need us, right?
Yeah, agreed. 100% agreed.
And I can't wait to be back.
Oh my God. Thank you so much again for coming on the OncoPT podcast. Like I said, as soon as I posted that last interview, people were already like, you got to talk about bone mets. You got to have her back on. I was like, well, of course I'm going to have her back on. It's just a matter of when. So we made it happen, y'all. Cannot wait to have you back on the podcast, Susan, because you're always one of my favorite guests.
Thank you.